Ronald Luria, Professor and Chairman of the Department of Preventive Medicine and Community Health at the New Jersey Medical School in Newark. Drug abuse is a problem of such dimensions in the United States that it has been well described as an epidemic. For years, legislators have attempted to deal with it unsuccessfully through laws, and law enforcement agencies have expended enormous amounts of monies in an attempt to choke off the source of supply, and this too has not succeeded. Now, in desperation, society has turned to the basic scientists and to the physicians in the hope that they can either eliminate or at least substantially reduce this burgeoning societal problem. The more basic question is, are we confronting anything new? Are we the only society that's dependent on the use of drugs for purposes of stimulation and pleasure? In this tape, we hope to take a wider view of drug abuse, placing it in cultural perspective and examining some of the ways it is being handled in the United States. Perhaps most important, we will be considering why the use of drugs is so universal and why it is so important to take a good look at the psychopathology of drug abuse instead of focusing so closely on the drugs themselves.
I know of no people who do not use some narcotic. Hallucinogens are used quite widely, but it seems that when you go north of Mexico and south of the middle of South America, the number and frequency of hallucinogens diminishes. And then there's the curious fact that we have in the New World so many more plants used as hallucinogens than in the Old World. There is no botanical justification of this. We don't believe that the Old World is poorer in number of species containing hallucinogenic constituents than the flora of the New World. There may be some difference, but they wouldn't be as different as the numbers of species used would indicate, because there are 90 to 100 hallucinogenic plants.
Dr. Richard Schultes is a botanist from Harvard University and certainly is one of the world's authorities in the area of drug use in primitive societies.
No botanist can tell you how many plant species there are in the world. If you look in the books, they will say 250,000. This is an estimate that dates back to 1888. I favor more the figure of 500,000. And a very, very small number of these have been investigated chemically. And when you consider the great number of different organic constituents that are found in the plant kingdom, and multiply that by the number of species that may have these, you can see what a tremendous task it is. But now, with modern sophisticated chemical means of identification, when you can now use micro techniques, the door is open for very great discoveries. And this opens the door not only to discover new hallucinogens, new narcotics, but new medicinally valuable plants. And that is why I am studying toxic plants, because even though a plant is so toxic it is avoided by primitive peoples, it's toxic because of something it contains. And just as in the case of arrow poisons, which are used by the natives to kill, and out of which modern medicine has extracted alkaloids which are used to prolong life in our medicine, completely opposite use, so some of these toxic plants might have extraordinary use in our society.
Do you have any idea of what percentage of the plant species are likely to contain either toxins on the one hand or mind-altering agents on the other?
I don't believe that it's possible to come to any meaningful estimate as far as mind-altering agents in plants for several reasons. One reason is we have no reason to suppose that primitive societies have discovered all of the plants that have mind-altering constituents in them. Some may never have been discovered. Others may not be used because they are otherwise too toxic. Some may not be used for superstitious reasons, and then something that we often forget, but the experimentation of the hippie movement has brought forcibly to mind. While true hallucinations are induced by a small number of constituents found in plants, mainly certain types of alkaloids, such as tryptamines and other indolic alkaloids, what to the general public are really hallucinations, although psychiatrists and psychologists distinguish them as pseudo-hallucinations, illusions, and other phenomena. These things may be induced by a number of toxic substances which so alter the metabolism of the central nervous system that these phenomena are induced.
Are there some plants that cause only auditory hallucinations?
Yes, there are several plants that have been reported to cause only auditory hallucinations, and especially in Mexico. There's a plant called siniquichi. The siniquichi is a shrub that occurs from Mexico all the way down the Andes in South America, but only in Mexico apparently has it been used. A tea is made of the leaves, and it brings voices from afar, and the natives have thought that this is a form of communication with the spirit world.
I suppose one of the great prospects for the future is that with the convergent activities of the botanists and the chemists and the anthropologists, the neurophysiologists and the psychiatrists, we will be able to take drugs that you will find for us botanically and find that certain of them, either initially or by chemical modification, can have very specific actions at very localized areas in the central nervous system.
I hold a hope that out of this study may come, to use a popular term, one of the new wonder drugs, of which we've had 20 or 25 in the last 40 years, starting with curare and the antibiotics and cortisone and so forth. Then you've also hit upon another important thing that we should bring out, that the importance of interdisciplinary studies in this field, as in other fields, is only just beginning to be realized.
Of the drugs that you've worked with, are not those of the ibogaine capi group supposed to be the only ones that are truly aphrodisiacs, and are there any that you've worked with that you would feel fit into that category?
I am not sure that there is such a thing in the plant kingdom as a physical aphrodisiac. I think that this may be laid, at least in primitive societies, in drug taking, to psychological states. I have no information on that, but if I were to hazard a guess, I would think that most of these hallucinogens are suppressants of the sexual desire.
As the experience with LSD suggested even in our society.
And as the experience with cannabis suggested too. Wow. In our society.
I was particularly interested in how structured the use of these drugs are in primitive societies as opposed to our society. Peter Sorokin from Harvard, of course, has emphasized in almost prescient fashion that we were moving down the road to a society in which was hedonistically oriented, and pleasure became, and has become, for many of our people, a major motive of their life in society. Now, is that true in the primitive societies? Do a lot of people, I mean, whether you call it generically escapism, but nevertheless, do a lot of people take it for fun, aside from divination or warfare or healing or magic?
Oh, the great majority of the cases, it's almost general that the use of hallucinogens and other narcotics, if you accept alcohol and tobacco, are highly structured. Now, the hallucinogens, almost all of them are used in a religious, magical, or medical sense. And you must remember that among primitive societies, wherever you go, these three things are very close and sometimes one. That religion and magic are closer in primitive societies than they are even in our own society, and certainly religion and magic is close in our own society. And that medicine is all part and parcel of the same thing among primitive peoples. Now, it's easy to understand why these things would not be overused by primitive societies, because when you structure something and it becomes part of a religious ceremony, people are very often ostracized or punished when they misuse this semi-sacred or sacred element. And then in many societies, the use and prescription of when you can use this is in the hands of a very powerful witch doctor or medicine man. Now there are evidences in the Orinoco of the hedonistic or daily use of hallucinogenic snuffs. But it is thought by anthropologists that this is a relatively recent innovation that is tied up with the arrival with missionaries, traders, other people from our society, with the arrival of affluence amongst the natives. And this may be, if you follow this through, a very interesting thing to study in connection with our own society, which, when you compare it with Elizabethan Europe, is extremely affluent. You must remember that when you speak of use or misuse in our society of drugs, most of them are taken not in the natural form. In our society, it's only, I think, I'm safe in saying, only tobacco and cannabis that are used in their natural form. And it is also interesting in this connection to realize that these are the two narcotics, as toxic as they are, that are the least troublesome, at least medically speaking.
The Aztecs and the Incas were apparently Catholic in their drug tastes. Is there any evidence that with those societies or any other primitive societies that drug-taking patterns played a role in deterioration of the society, or that the society permitted unlimited intoxicants at any time in its course?
I don't think that's answerable yet. I believe that in the Aztec Empire, among the Aztecs, very few of the general public took these drugs in any concentrated way. They were mainly witch doctors, priests, doctors, or noblemen, or great warriors. Now, in the Inca Empire, it wasn't long before the Spanish arrival that the use of coca was let out to the general public. Then when the Spaniards came, the initial reaction of the Spaniards was prohibition of this devil's weed. And then they, too, found, after a few years, to get these people to do more work, they let coca once again be cultivated and be used by the general public. And in our own times, the United Nations has tried to convince these Latin American countries to prohibit coca. Some, like Colombia, have, and kept the prohibition. But other countries have found that which is an axiom, when you take a culture trait immediately out of a culture, something is going to fill that hole. If that culture trait has had 1,000 years as part of the culture.
In recent years, the drug scene in the United States has changed dramatically, and with it, there have cropped up numerous theories as to why it is not just a transient obsession, but rather a response to societal or individual problems. Dr. Charles Dahlberg, a New York psychiatrist, is preeminent in the field of assessing relationships between drugs and personality, and I've asked him to discuss this issue.
Once in a while, I see youngsters who have excellent past histories. You go deeply into their high school life, and they've got good grades, get into good colleges, they were active in sports in the high school newspaper and things like that, had a lot of friends, popular and so on. And then they get into some drugs, amphetamines, frequently LSD. They sink into a deep depression, lose all interest in anything, not even much interest in the drugs, except that the drugs themselves will relieve their symptomatology. And my suspicion is that there must have been some sort of a latent problem going on there that was triggered by the drugs and the general life that they were leading. And as you know, with amphetamines, if you're in it very heavily, you're likely to suffer from malnutrition and vitamin deficiencies and all sorts of things like that, excessive fatigue. But I think that probably there was a hidden depression that was kicked off by the drugs. And that's not an excuse, because I don't think all of these hidden depressions and hidden schizophrenias have to be kicked off. You can go through life with a lot of mental illness that doesn't have to surface. This sort of thing, I think, happens to a lot of youngsters when they leave home for the first time. When we talk about a loss, we think of something being taken away. But it's equally a loss if you give something up. And one of the big jobs that the adolescent has to do is give up his parents. And this happens ordinarily at certain critical times, and one of the big times it happens is when he's going away to school to spend a long time away from home. It's not that something is taken away from him. He goes away with great high expectations, and the mothering and parenting and so on that he had before disappears. It isn't there. And he expects wonderful things, and they don't happen. Falls behind in his grades. Somebody offers him a joint. He feels good. The demands of college are more than the demands of high school, but they're a different kind of demand. That is, he doesn't have to turn in papers every day or do his homework every day. He can put it off for a month and nobody will know the difference. And then he gets far behind and he starts worrying. He sinks more into depression. Somebody tells him that amphetamine will allow him to stay up and cram for his exams, which happens. And he may do pretty well on the exams, but then a lot of times he doesn't. And he gets to finding that this is a real life of great excitement for him. And pretty soon he is doing nothing except hopping around, having a great time, high on amphetamines, and then he discovers LSD and mescaline and these things. This, of course, is the typical story I'm giving you now of the hippie generation. Now, that doesn't happen quite so much in quite that exact fashion anymore. And the kids, I think, are a little more cautious than they were. But I believe that these drugs are serving, in a great sense, to fight the depression, to fill up a loss. The rituals that go up around taking the drugs are terribly important, and they substitute for a lot of family rituals or religious rituals or one thing or another. The whole problem of getting a drug, for instance, can constitute 6 or 8 hours of conversation in a dorm between a half a dozen kids. One patient of mine told me that pot was the greatest time killer he ever had, and that's one of the problems of adolescents. They tend to get bored very easily. They need outside stimulation. And a few of them, of course, go on to heroin use. That's a growing problem in our cities, among the middle classes, in the suburbs, and one which is going to be very, very difficult to solve.
One of the things that interested me in what you were discussing, you related boredom and depression. In looking at communities, I think all of us who've been involved in epidemiologic studies become progressively more intrigued with the phenomenon of boredom in our society. But I take it you feel that what looks on the surface as if it were just straightforward external boredom is frequently covert depression.
Frequently, yes. But it can go beyond that, and the boredom, when it becomes very severe, must mean that there is something that is stopping the person from finding something to stimulate him. You know, this world of ours is remarkably full of interesting things. You have to have somebody stopping you from finding something interesting. And the only people I know generally who can't find something interesting have something going on like a depression in them, or else they're locked up in jails or in hospitals.
Well, it's obvious that depression is such an important aspect of the involvement, of deep involvement in the drug scene. Is it your feeling that depression is becoming more prevalent among young people in American society today? And if the answer to that is yes, why do you feel it's so?
When people have got nothing to do and very little hope, they have to find something. The depression now that we see is more from, I think, a disappointment of having been brought up to expect the moon and find that the moon isn't what you expected it to be. And this whole idea of expectation leads us into other generations in other countries, in other parts of the subculture, who grew up knowing what they were going to be because it was what their father was, and that was what their father was before them, and they had little in the way of aspiration. And I suspect that, well, some of those people must have been very depressed, but the average person under such circumstances, probably if he was depressed, it was along the lines of a certain amount of apathy. There is one thing I want to interject here while we're still on the subject of depression, and that is, this is a problem because of the laws, and that is a lot of people, for one reason or other, who are using drugs, and if I'm right, suffering from a certain amount of depression or trying to treat their depression with the drugs, end up in jail. Now, probably next to losing a limb or something like that, ending up in jail for a few months is the ultimate deprivation. And it is absolutely bound to increase the depression. And one of a number of things are going to happen. The person is going to become very seriously clinically depressed. He's going to search for companionship. He'll find companionship among thieves, criminals, very possibly, learn from them. He'll learn antisocial behavior. He will certainly learn to hate more than he hated before, and he will certainly develop probably a greater craving for drugs. Now, it may be necessary for other reasons to invoke jail sentences, but I am absolutely convinced that it does individual harm in these situations, and that it's perfectly predictable what happens.
So that from the psychiatric point of view, the user ought to be given some, if you have to have the drug proscribed, ought to be given some sort of punishment that does not entail incarceration.
Something that helps him rather than hurts him. Yeah. Something that decreases the deprivation rather than increases it.
Can I ask you to turn from that a little bit, and since you're one of the people who was most involved in LSD experimentation in psychiatric practice, how do you feel we stand with LSD now as far as its potential medical uses?
There still seems to be some reason to think that LSD used in a total push program is of value in alcoholism. The use of LSD as a facilitating agent in psychotherapy, and when I say LSD, I'm including this whole group of hallucinogens, like the shorter acting ones and so on, psilocybin, things like that, which may be better because they are easier to handle. The use of it in psychotherapy as a facilitating agent seems to be dying out. I think that's unfortunate because I think it has a real potential there. But it's one of those things that has happened because of the bad press and because of the misuse of LSD. It's the story of hypnosis, which seems to have some value, but it died in medicine for 50 years or so because of because of the exploitation of it. What I have been doing some work with recently is using it as an agent in dying patients. And there, the main work on that has been done down at the Maryland Psychiatric Research Center. But I've done a little of it recently, too. Their results are extremely encouraging. I'm terribly enthusiastic about it. One of the big problems, you know, that a person who has, say, a terminal cancer has is that they're caught in the bind of cheering everybody up who's around them. And nobody wants to talk to them about it. And so there is this conspiracy of things not being so bad. As one woman said to me, what do these people think we've got, a common cold? And they get a chance to talk straight. And then they can get out of this, some of this, relieve some anxiety, and they can feel a lot better. It is a good analgesic, incidentally. They get relief from pain for about 8-10 hours.
Do you find that after the LSD experience, they can not only discuss the tumor problems directly with you as a therapist, but can also go into the family and discuss it more freely there, too?
Into the family and with their physicians, if the physician is able to do it. I mean, it's a two-part transaction. The other people have to be able to be cooperative. Now, I'm not saying that you should say to these people, you know, lady, you got cancer and you're going to be dead in 10 days. I'm not saying that you should tell these people that there is no hope, but I am saying that I think that a good many of them know a lot more than anybody is willing to talk with them about. And if they have a chance to talk freely and experience a good deal of their anxiety, they can be a great deal more comfortable.
I've seen the needle and the damage done, a little part of it in everyone, but every junkie's like a setting sun.
I've been taking drugs for about 7 or 8 years, off and on, you know. It was an excuse to hide, you know, that's all it was. And I signed up with this program about a year ago. I waited 5 months. Then I called every week and so forth and so forth. And then one day I went back there and I says, this is it. Yeah, I need help. I'm coming here for help. And nobody was doing nothing for me. It was either I go to jail or I'm going to die. That's where I was heading, you know what I mean?
I've been using dope. I believe, as I'm correct in saying, my first experiment was 1943. I got hooked in 1945. I'm a musician by profession, and I used drugs off and on until 1970, I believe it was, although I have tried many, many times to kick. In my hometown, they had a program which was really just cold turkey. You went to court and had yourself put away in the house of correction. I did that many times.
I had used heroin for about 6 years, And during that period, I'd been in and out of both mental institutions and drug hospitals, trying to kick and get myself together, always unsuccessfully. After a period of 6 years, I'd never been in jail, but everything else in my life had gone completely awry. I lost my husband and my children and everything. So I started seriously thinking about getting clean.
All of these drug users are on methadone programs. The evidence suggests that methadone is a perfectly good solution for some of our addicts, although there is general agreement that a better non-narcotic heroin substitute should be developed. Dr. Joyce Lowenson is director of one of the largest and most respected methadone maintenance programs in this country. I would like her to discuss the results of her program to date.
Interestingly enough, the results on our program are very similar to those of the original Beth Israel program. We had thought, since we were taking patients who had more problems prior to treatment, that perhaps our retention rate might be lower, but in fact this hasn't been so. Our retention rate is roughly between 78 and 80%. Now, what this says, I'm not sure, because we do at the present time have many patients who are younger and who are harder to treat and whose history of addiction has not been as long and who haven't suffered as much as a result of it. All of these being factors which supposedly motivate a person, people who have spent less time in jail. Nevertheless, the retention rate remained high. This may be a tribute to the staff because they make such a determined effort to help patients and to keep them in treatment.
Is it too early to make any judgment about whether the patients with, say, concomitant alcoholism or major psychopathology do as well as those who don't have those problems?
No, I think that you have to break that down. Patients who come in with a problem of alcoholism or who develop a problem of alcoholism after they start taking methadone do present a very serious problem. And within our own program, we've tried to develop something analogous to Alcoholics Anonymous.
And their prognosis, I take it, is a bit more bleak.
It's bleak, and yet we find that if we were free to treat all patients who have a history of addiction the way we treat patients who have no history of addiction, I think that we could say the prognosis would be better. But these problems are more difficult to deal with than the abstinence from heroin once that craving is controlled.
Right. So the double addictions are particularly difficult. How about the psychiatric patients with, say, schizophrenia? Do they do worse than the other people in your program?
Well, where the patients are able to get adequate psychiatric follow-up, they seem to do quite well. If you have somebody where you're constantly fighting to get a psychiatric service to accept him because he has a history of addiction, the odds are against him. And this is really unfortunate, and it reflects the need really for educating psychiatric staff from the psychiatrist right down through the psychiatric nurse and the attendant and the psychologist and everyone else on the staff to recognize that because an individual has a history of heroin addiction does not mean that he's untreatable. To get a staff to understand how methadone maintenance will give control of the patient, control in the best sense of the word, that you're controlling the qualities or the needs that make him create such ward problems. If you can achieve this, then I think the prognosis for such a patient is good. I mean, as good as it could be,
right,
with or without a history of addiction.
So that if he has major psychopathology, you have to be prepared as a psychiatrist for the emergence of those problems more overtly during methadone therapy. But if you treat those effectively and treat his underlying psychopathology, his prognosis really is no more grim than as if he had heroin addiction without that particular problem. What's your own feeling about the duration of methadone treatment for the individual who's put on maintenance? Should we be taking more of them off, or should they be on for prolonged periods of time? Is there any way to make any judgment about who should come off and who should stay on?
This is the problem that we're trying to address ourselves to at the present time. Initially, it seemed to me that the important thing in putting a man on methadone was to give him a chance to make some kind of social adjustment and to become productive and maybe to enjoy some of the pleasures of life. But as we see the population of addicts increasing and the number of those who are good candidates for methadone maintenance, we realize we have a vast public health problem. The idea of maintaining maybe 100,000 or more people on methadone without considering withdrawing, I think, is unacceptable. I think everybody agrees that we'd like to find a better drug.
Well, I take it your feeling is that a certain percentage of people would do better in therapeutic communities, and a certain percentage would do better in say, some other cyclazazine or some different modality, and the problem is to try and define who might do better in one modality as contrasted to another.
Yes, I think it's imperative that we do this. First of all, we have no real data on the therapeutic communities. And surely there is a certain group of patients who will do well in a therapeutic community. You hear figures that vary anywhere from 5% to 90%. I'm sure the truth lies somewhere in between. And the therapeutic community plays other roles, surely in prevention and education. But as you point out, it's important that we be able to develop these other objective criteria.
How about the use of methadone in an office practice? There are now various medical and psychiatric groups urging that the drug be freed up for utilization by a physician in a private office practice. Do you favor that?
Again, I feel that this would be reasonable in a group of well-stabilized patients, that these patients could then be followed by an individual practitioner. But practitioners really don't have all the other ancillary services that they need. The average person who has been using heroin requires help in getting a job and getting housing. He really requires the services of a social worker.
Of course, the other thing is that if you gave methadone-like drugs out for use in private practice, somehow the psychiatric profession or the medical profession as a whole would have to have the capacity to police itself so that we would not run the risk of the same problem that caused the British to completely modify their free prescribing system.
Right. There's also another factor. I think it's untherapeutic for a psychiatrist to be prescribing methadone to a patient whom he's trying to treat in therapy. It introduces certain restraints on the part of the patient and unwillingness really to be open about the kinds of problems he's encountering for fear that the methadone may be withdrawn.
No, I think that's a very important issue. I think most of us who do not have psychiatric training have focused in what obviously is parochial fashion on the more prosaic issue, namely that if you permit psychiatrists or internists or general practitioners to give out methadone, as in England, a small number inevitably will, for one reason or another, massively overprescribe, and that this will result in the public denigrating the entire methadone approach. So we've been very cautious about advocating the office use of methadone, simply because we feared that if this were abused, that the public reaction would result in elimination of methadone as a modality entirely.
From a public health point of view, I think that's a very important argument.
The therapeutic community is another modality of treatment for the drug abuser, used with some success for certain patients. Reverend Lynn Hageman has for some years directed Exodus House, one of the best therapeutic communities in the country. I would like to ask him what these communities offer the addict and what is the likelihood of success.
The therapeutic communities all have in common the belief that the addict, however sick he is, however immature, however messed up he is, has the capacity within him to make certain existential decisions about his life. He can say yes or no at given points to certain situations. And this, they all agree, has to be capitalized upon, and they all emphasize this capacity to make commitment. The second thing they have in common, at least it seems to me, is that all of them hold to a particular worldview, and each of them has its own vocabulary by which it expresses this. But essentially they're saying the world is a mess, and it shouldn't be that way. They have both an ideal view of what the world ought to be and what they feel it could be, and on the other hand a rather realistic appraisal of the fouled-up condition in which society and culture in general find themselves. The third thing is that they believe that within the framework of their own particular therapeutic community, this screwed-upness, this messed-upness of the world, of culture, of society, is being turned around in an encapsulated environment, that somehow something effective takes place that effectively transforms the alienation, the pain, the dishonesty of culture and society for the participants in the community. The fourth thing they have in common is that they all seem to believe that this experience of success in restoring something of the wholeness and health of a community has implications for larger society, that somehow the therapeutic community in its life provides a paradigm, an illustration of what society and culture as a whole could be about if they would but learn from this experience. There are a group of therapeutic communities which follow rather strictly a Synanon model, which, among other things, has a rather clear-cut position that in dealing with the addict and his hang-ups, his pathology, it's important for the addict to act as if he were a healthy person, to go through the motions of wholeness and strength, even when he's feeling weak and when he's feeling dependent and sick. There are other therapeutic communities, such as my own, which are more oriented towards what they feel is reality, in that they emphasize a frank recognition of a person's bad feelings about himself rather than an act as if motif. So that in my particular therapeutic community, the addict is relatively free to come in and out outside of his working and therapeutic hours, during which time he knows that every time he walks out the door, he will have the opportunity to buy drugs from one of the local neighborhood pushers.
Is it your feeling that this is mandatory for the therapeutic community? Does the addict, in addition to his initial commitment and motivation, have to test himself in the real world with work and employment?
I think that he does. Now, there may be exceptions to this, and there may be other ways of reaching the same end. It may not be necessary for every therapeutic community to place the kind of emphasis we do upon work as a therapeutic instrument. But if there are other ways, it has yet to be shown, I think. It's not just a matter of having a job to earn a living, but it has as much, I think, to do with the addict determining at a very deep level for himself that he is indeed a person and a person of worth.
What do you do if somebody comes to you who has major psychiatric problems? How do you screen them out, if you do screen them out? And among those who are definable as having such problems, what happens to them while in the therapeutic community, especially in the therapy sessions?
If the psychiatric problem is so severe that it's obvious the person is not going to be able to communicate, then of course that means referral. But if it seems that he can at least go through the motions of functioning in a community, we'll accept him. I can't say that we've had great success with paranoid schizophrenics, but we have found that we can keep them in treatment in many cases for protracted periods of time, and in a few cases they have completed the program and done rather well.
So that for a psychiatrist who's considering referral of a young drug abuser to a therapeutic community, it really would be enormously important for him to make absolutely sure he understood the nature of that community so that he is not endangering that particular patient by thrusting him into a situation that can be inordinately threatening if the group happens to be very much oriented toward abrasive confrontation.
Well, I would think so. I would think it also important that there be psychiatric resources available in the therapeutic community, both to train staff so that they're sensitive to these problems, and secondly, to be available for direct involvement, not only if points of crisis arise, but as a part of the ongoing therapeutic process.
Have you noticed over the last decade that there's been any profound change in the addict personality, and you noticed major differences between the white addict and the black addict?
It's hard to answer that question, I think, largely because the population itself has changed rather radically in that we're dealing with a much younger group of people than we were, say, back in the late 50s and early 60s. At that time, the average age of the addict with whom we worked was somewhere in the neighborhood of 28 or 29, and now it's down in the low 20s, and this makes for some differences. At the same time, I think that we've had some chemical factors that have made for personality differential. Again, back in the 50s and very early 60s, most of our addicts were bona fide heroin addicts. And since, 62 or 3, there's been a steady increase in mixed addictions, mixed dependencies upon all sorts of drugs, and this makes for some interesting differences in approach, including the necessity for being aware of actual organic damage that's been sustained, particularly with barbiturates and amphetamines. There are certainly, I think, some very real differences that relate to causative factors, and this is reflected then in the personality of the addict. That is, it would seem to me that most of the black and Puerto Rican ghetto addicts with whom we work began their drug use because the drugs themselves have such an effective analgesic quality. They do buffer pain considerably and are so effective in this regard that one would suspect that maybe the drug user in East Harlem is likely to be a person who is simply inundated with sensation that he can't handle, both from within and from without. And so he turns to drugs as a means of finding some kind of stasis that will provide him with a sense of balance. The white middle-class addicts with whom we are working increasingly, however, seem perhaps to have become involved with drugs more as a matter of, well, crudely put, boredom, if not outright protest against a somewhat icy environment that they perceive as militating against any genuine involvement, any genuine commitment, really not knowing how to go about the first steps of making commitment, but simply being icy cold toward the world around them and toward their own interior lives, and being desperately hungry for sensation, for feeling, for being in touch.
What about the area of prevention? Do you think that there is a role for the therapeutic community approach in the prevention of drug abuse in our society?
I think there is. I don't think that role is yet clearly defined. We certainly see some areas where the therapeutic community can be and has been useful in a limited way. That is, in developing corps, cadres of trained ex-addicts who are aware and knowledgeable about not only their own limited experience, but also some of the larger mental health dynamics of the problem, who can be extremely useful in communicating. I think that one of the very real things that the therapeutic communities can do is to help society as a whole face up to certain very real problems that all of us face, particularly with our young, in terms of redefining what we mean by pleasure. And we desperately need to redefine the value system of our culture that places such a premium upon immediate self-gratification and pleasure at the expense of almost all other values.
The audience for this tape is predominantly psychiatrists. What would you advise them, having your long experience in the drug field, in regard to ways in which they can become more effective in this whole area of drug abuse?
Certainly the first thing the psychiatrist ought to do is to recognize that sooner or later he's going to have to deal with this in a professional way, that he really can't cop out completely from facing up to it. He's going to face it, have to face it. This means becoming knowledgeable about the literature that's available. Secondly, I think that he ought to make some effort, if it's at all possible, given the busy lives psychiatrists lead, to make some effort to attach himself professionally to a treatment program and allow himself to be educated. And in the process, also, hopefully, to be able to do some education about his own field that can be tremendously useful to the therapeutic communities. I think that the kind of opportunities that might arise if this were more widely done would be almost unlimited, both for the therapeutic communities and for the psychiatrist.
The drug problem continues to be severe. and our immersion in possible solutions to it extensive. It brings to mind other problems as well, perhaps the most important of which was brought up by Dr. Schultes when I asked him if he felt we should limit the number of intoxicants available for pleasure.
I think any major intoxicant, including alcohol and to some extent tobacco, is a drag on the economy, if not on the health of a nation. And therefore I would hope that some method of control rather than prohibition would be successful. But in the case of cannabis, I feel that we don't know quite enough about it yet. It's going to be interesting to watch the developments in several countries in the attempts to control tobacco.
Do you have any feelings about the future of this country in terms of mind-altering drugs? Is there any way of predicting where we'll be in 1980 or the year 2000?
I don't subscribe to the fact that people are now more evil or because they are taken to violence or because they are taken to drugs or because they're taken to Jesus or because they're taken to rock and roll. But I do feel that this couldn't have happened in days that I wouldn't want to see come back, when people worked every waking hour of their life.
Boredom, depression, lack of identity, all seem to contribute to the attractiveness of drug use. I asked Dr. Dahlberg what role he felt psychiatrists could play in this burgeoning crisis.
Well, you better than anybody else know that there are two problems. There's a public health problem and then there is an individual treatment problem. And I deal particularly with the individual treatment problem. There, I think you generally have to have a real indication for psychotherapy before you can treat a drug user. That is, he has to have some sort of symptoms like an overt depression, recurrences from LSD or a schizophrenic process. Then you can treat the person. I don't care if they're a heroin addict or what. Then you can treat them. But you treat them primarily as a psychotherapist. And the drug problem tends to handle itself. It drops away after a while. It's a little more complicated with heroin, but it tends to handle itself. I think that what we can do if we have some expertise about the drugs themselves, about the pharmacology and the effect on them, act somewhat as advisors. But I think that the real problem is for the community to build up its own programs of help, education, and support. And I think the most effective people in doing that are the former drug users, the youngsters.
But how about for the person who's depressed? Would they still be capable of handling the depression complicated by drug use? We've always been very nervous about having personality problems handled by ex-drug users who weren't really authoritative in the field of psychiatry or psychology.
Well, it's true. They learn something from the seat of their pants, you know. Some of the drug users know a good deal about depression, and as a matter of fact, a lot of them have cured their depression by getting involved in helping other drug users. There's nothing like involvement in something to help a depression. And I think they can learn something. And the important thing, though, is that they can get to the user. I have a good deal of success, as you've said, with the drug users, but they're a suspicious lot. And the medical profession in general has been 5 years behind them. Takes time to catch up with them. That's not a criticism, incidentally. We're always behind. You have to be behind.
But I take it that means that for an internist or a psychiatrist to deal with a given drug user, that it's imperative that physician know the drug scene.
Right. And he has to know today's drug scene, at least a little bit, not yesterday's drug scene.
George Bernard Shaw once said that we are made wise not by the recollection of our past, but by the responsibility for our future. We have many overriding concerns in the drug problem that pertain to the future. We in the medical profession persist in looking in totally insular fashion at the perils of marijuana or the dangers of LSD. Clearly, we can no longer do so. We must realize that we, like almost every other society in history, have used drugs for pleasure or escape or some other cultural motivation. Since we are no different from other societies, we must do what other societies have done before us. We must make sensible judgments about how many drugs we wish to have available for intoxicating purposes. We must decide between national use and societal tragedy. As physicians, we might surely claim a part in making that decision.
Produced by the Council for Interdisciplinary Communication in Medicine Limited under a grant from SmithKline and French Laboratories.